Topic today is going to be on some common pediatric sports related topics that might roll through the office here. Um, do, do, do. So just starting off with just kind of a refresh of all of our secondary ossification centers that we've got going on in the body here. Um, on the right, we've got our the left of the screen, we've got our lower extremity stuff. So really today we'll focus on some of those hip spots, the AIIS, the ASIS, the ischial tuberosity, the patella, the tibia, and the navicular and the calcaneus. Whereas in our upper extremity, we've got a little bit more detail here about the age of appearance on X-ray plus the approximate age of fusion. You can see that between our girls and our boys, we see about a 2-year difference there. So always keep that in mind with your patients as they kind of come in here. So we'll start off and kind of walk our way from upper extremity down to lower extremity, starting with little leaguer shoulder. So little leaguer shoulder comes in and it's a proximal humeral epiphysiolosis or a Salter-Harris type 1 injury, commonly seen as it's named in our overhead throwing athletes, but also in our racket athletes as they make some similar maneuvers there. It is distributed wrong, kind of their adolescent years, 11 to 16. It's going to affect our males more than females. And it's got some significant risk factors that we can kind of account for. Poor pitching mechanics is going to be a mainstay here, and especially the use of breaking ball pitches before they hit that skeletal maturities point. Um, there was a study kind of by Lyman that showed that throwing a curveball before skeletal maturity increased that risk of shoulder pain by 52%, which is pretty significant there. Breaking down on the right of the screen, we've got some guidelines from USA Baseball and Little League itself that talks about the daily limits of pitching by age. So USA Baseball, once you get past 15, doesn't have any daily limits on pitching, but Little League definitely kind of enforces that a little bit more. So um, that 9 to 14 rate should really be conscious about how much they're throwing here. That includes practice and games. So um, something you should work on with your players and your coaches as well. So these patients are going to come in, they're going to complain of pain that localizes to their dominant arm, their throwing arm. Pitchers present with decreased pitch velocity. They're going to feel their accuracy is a little bit worse because of the pain. And the pain's going to be worse in the late cocking and deceleration phase of the throwing arc. It's going to improve with rest. And then on exam, you're going to notice tenderness to palpation at that anterior lateral or posterior aspect of the proximal humerus. And they might have some finding that isn't always present. And then you're going to notice this pain is reproduced with rotation of their shoulder. Breaking down through just a reminder of the stages of the throwing motion. We starting with the wind up. We're going to go into the early cocking motion as the ball's behind us, and then the late cocking motion as we power through acceleration and deceleration. So for little leaguer shoulder during that late cocking phase, as that shoulder gets maximally externally rotated, that's going to be pretty painful and put a lot of torque through that growth plate, which is going to lead to kind of that enhancement of the little leaguer shoulder injury. During deceleration, those opposing forces of the arm motion and the rotator cuff cause eccentric physeal stress. So that's going to worsen the injury over time as well. When they come into the office, we're probably going to get some radiographs. You're going to want to get an AP view, a scapulary Y view, an axillary view. You're going to pretty typically see the widening of the physis here. You may see some metaphyseal bony changes, and then some patients just have a normal X-ray as well. So you always have to keep that in mind that the X-ray doesn't necessarily rule out this presentation. So should be if it's in your suspicion, you should consider it even with normal X-rays. For management for these kids, we're going to want to shut them down from pitching for 3 months as they kind of progress to a pain-free state. We're going to get them into physical therapy for increased range of motion, stretching of that posterior shoulder capsule, strengthening the rotator cuff, and working on their core strengthening as well. Once they kind of started to progress through PT, they're P3. We're going to start that progressive return to throwing program. And we're gonna have to make sure that their mechanics are improving. You might want to discuss getting a proper pitching coach with them. Um, like I started at the beginning, we're going to discourage any breaking ball use until they reach that skeletal mature age. And we're going to really enforce those pitch counts. So we want to lower their risk and make sure that they're taking time off and avoid that year-round pitching. And I know that's very hard in today's middle league and, kind of financially driven sport environment. But that's something we really want to hammer home with a lot of these patients, and especially their parents too, that these kids need some rest. Moving on down the lower extremity or the upper extremity, we're going to go to little league elbow next. So this is classically the apophysitis of the medial epicondylar growth plate, but can have kind of a wider spectrum of disease as we're realizing now. So we also have to consider kind of avulsion fractures at the epicondyle and also the UCL injuries. So our highest incidence, this is going to occur in our 9 to 10 year olds, and it's going to have a lot of similar risk factors that our little leaguers, our shoulder is going to have. Where if we're throwing more than 80 pitches a game, pitching round year, throwing high velocity fastballs, and those breaking balls are going to come in. So now I mentioned with the shoulder, the curveball specifically increases their risk of shoulder pain. Throwing balls with more of a twisting motion like a slider is going to increase the risk for little league elbows. So, if you're making sure we're taking a good history for these pitchers that are coming in and knowing what type of stuff they're using out on the mound there. Um, mhm. And so, and then the bottom here, just kind of breaking down again that early stage, that 9 to 10, we're going to think more of the apophysitis. In adolescence, we're going to have some more fusion of the ossification center there, increase our risk of the avulsion fracture. And then as we're kind of into adulthood, our college age kids, we're going to think more about a UCL tear there. So again, the repetitive valgus loading of the elbow during the throwing motion causes repetitive micro trauma onto the apophysis or the apophysis. Um, and these kids are going to come in, they're going to have a lot of pain and swelling in their medial elbow there. For the apophisitis, this is going to be progressive worsening over time. They're not really going to present with that typical traumatic experience during one day. They're going to notice some decreased range of motion, especially in full elbow extension. Whereas your key avulsion fractures are going to be a little bit of older kids. They're going to present with a pop. They're going to have felt it at a specific time in their pitching routine, and they're going to be pretty much asymptomatic prior to that point. They too will have some decreased extension in their range of motion. And then the UCL sprain will kind of present with a similar onset as that apophysitis with kind of slow buildup and then maybe um, a spot where they've kind of hit the maximal point of tenderness. And they're going to have positive provocative testing though, because their elbows will feel lax and unstable because they're actually injuring the ligament there, not just the apophysis. Here we've got some plain radiographs showing the widening of the medial epicondyle, the physis here on the left, and compared to the contralateral side, showing the apophysitis there. Whereas on the MRI here, we're seeing it a little bit more in detail. You're getting some of that bony edema and swelling on the T2 coronal cut. When we're considering our other, the two other things in our differential for the apophysitis, we'll notice the stark difference between the avulsion fracture on radiograph here. And then on the MRI, you're going to see more disruption of the UCL in the T2 phase here. For management of the little ear's elbow for apophysitis, we're going to want to slowly shut them down in the absence of fracture. We're going to shut them down for about 4 to 6 weeks, so a little less time than little ear shoulder. They're again really want to focus on physical therapy for flexibility, strengthening the core, making sure their progression to throwing is utilizing proper pitching mechanics and that they are sticking to a pitch count when they're throwing. For the avulsion fracture, for our primary care guys, we're going to want to refer these out to our orthopedics department in case they need surgery. And for these UCL injuries, we can start with non-operative management, but they might require reconstruction if they have complete disruption of that UCL seen on MRI, or you're noticing some significant insufficiency on exam. Um, so things to keep in mind that we're not going to always just treat these non-operatively. Moving down into the lower extremity, the hip. There's 7 apophyseal locations in the hip. The iliac crest, the ASIS, the AIIS, your greater trochanter, your lesser trochanter, your pubic symphysis, and your ischial tuberosity. And so we know that these are, pretty common attachment points for a lot of our lower um, extremity muscle groups. And we want to be mindful that these are also at risk sometimes for avulsion fractures, muscle strain, but also apophysitis seen in our younger kids here. Starting at the ischial tuberosity, we have ischial apophysitis, which is an overuse injury that leads to pain and swelling at that proximal hamstring insertion. Our radiographs here could be normal, or we'll show that classic widening of that apophysis. We're going to want to treat these kids with activity modification. These can be at high risk for avulsion fracture, so we might need to shut them down, especially in your kind of elite athletes that really won't want to be taking that time off or won't take it easy if they're back out there on the field. So you want to give them typically about 4 to 6 weeks until they're pain-free and begin a gentle guided return to sport. And using kind of pain as that guide. If that pain's starting to come back, we need to scale back on their activity level. And then we want to focus on pelvic stabilization and core strength again for physical therapy, so they're not overexerting their stress on the growth plate there. Like I said, that spot is high risk for avulsion injury. So this is what we want to look out for is the ischial apophyseal avulsion injury. And these patients present with a sudden onset of pain after an explosive activity. So our sprinters and our jumpers, they're going to feel a pop in their gluteal region there. And on physical exam, they're going to have exquisite tenderness at that ischial tuberosity and may present with swelling or significant ecchymosis as well. They're going to have significant weakness in knee flexion. And when you passively stretch them at the hip into flexion, they're going to have pain as well. This is the evidence of the bony edema and then a fusion on the MRI for this ischial apophyseal avulsion. So if you're getting the X-ray, it doesn't look too clear. It should have a low threshold to go get further imaging to make sure we rule this out. Um, at our next site, the ASIS, is another spot that can become prone to avulsion fractures. Um, This is more due to the forceful contraction of the sartorius in your tensor fascia lata. Typically, this is going to be our male patients in high school, 14 to 15 years old. Their physical exam, they're going to have weakness in their hip flexion and with knee extension. We can usually see significantly displaced fractures on X-ray here, um, but we might miss smaller bonier segments. So this one has a nice left-sided apophyseal fracture that you can see here with a little bit of displacement. Whereas if it was smaller, you might not see that. So you might need a CT or an MRI to really confirm this diagnosis here. This is another area where you can get apophysitis as well. So, we're probably getting these radiographs when these kids come in, and keep an eye and mind their age range. The next spot down is going to be our AIIS, or that anterior inferior iliac spine. These injuries are going to be more due to forceful contraction of the rectus femoris. So you're going to get this as that hip extends and the knee is flexed. This happens a lot in our kicking sports, so like our soccer or kickboxing. These kids are going to put a lot of eccentric stress at that joint or that growth center. Um, they're going to have some significant tenderness on that AIIS, and they're going to have significant ecchymosis as well as weakness in hip flexion. And this one is pointed out by a nice arrow sign on the left side of that hip as well. So you're going to see an avulsion on the radiograph. For these avulsion fractures, a lot of them do well with non-operative management, but it's always better if we catch these early. So we want to make sure we're within that first month after injury, and be mindful of when we need to refer to our surgical colleagues. So if there's displacement with greater than 2 centimeters or a significantly large fragment, or if they're getting prolonged symptoms and painful non-union after we've done some non-operative management, it's time to get them over for a surgical consultation there. Moving down towards our patella, we have Sinden-Larsen-Johansson syndrome. So this is inferior patellar pole apophysitis. So this is caused by a traction at that inferior pole patella by the patellar tendon. It's going to have an insidious onset of pain, lead to some swelling at the inferior patellar patella. That pain usually occurs during or after activity, and it's going to be common in our kids aged 10 to 12. A lot of them are going to be playing our jumping sports, volleyball, basketball. And so kind of like a jumper's knee presentation as well. On X-ray, we're going to see fragmentation on that inferior pole here. And if you're not sure about the X-ray, you can also get an MRI, which will reveal similar findings. But the MRI will also help us rule out a patellar sleeve fracture, which would be in your differential diagnosis for these kids as well. You can also use your ultrasound skills if you're feeling confident in your probe, and find similar findings here at the inferior pole of the patella. We can see these cortical markings here for that fragmentation. And so might not have to send them all the way for an MRI. For management, a lot of these kids are going to do well with conservative management. You're going to do activity modifications. So for this, you're not necessarily shutting them down. It's going to be pain guided activity. So they can return to light jogging, light running. You're going to want to take them back from like the heavy participation like games or practice at first, but they can slowly progress. They can use their Motrin, their Aleve as needed for pain. Icing will help as well. And then you're also going to want to prescribe a patellar strap that should be worn on the tendon in between the patella and the tibial tuberosity itself. These kids are okay to let progress quickly because they have a low risk of avulsion and they rarely need immobilization. But if you've got a kid that's super painful, you can always consider it. I had mentioned the patellar sleeve fracture being in your differential diagnosis, but it is relatively rare. So about 1% of all fractures in peds, but it is half of our patellar fractures. So its peak incidence is going to be a little bit older than the Sinden-Larsen-Johansson syndrome, but it's still within that typical age range. And it's going to be a separation of the cartilage sleeve from around the patella. It's going to present with more of a sudden onset of pain, kind of like our apophyseal avulsion fractures. And it's usually associated with jumping or traumatic events. On exam, you're going to feel a palpable gap at that inferior patellar pole. And if the rupture is going to be distal to the patella, it's going to cause some patella alta. If it is proximal, you might get some patella baja. The extension mechanism may still be intact, but they might present with just an extensor lag. So you need to be careful on your physical exam that just because they still have that extensor mechanism, it doesn't technically rule out this fracture. Over here on A, just an example of what that, just an illustration of the sleeve coming off. And then we'll have radiographs here, as well as the CT renderings of the image here. We're going to see small flecks of bone that's going to be adjacent to that superior inferior patellar pole. I already talked about the high rising or low rising patellas. And again, if you're unclear with the radiograph, low suspicion, get an MRI, get an ultrasound, confirm that diagnosis, make sure you're not just dealing with apophysitis before you let them get back too quickly. For non-displaced fractures with an intact extensor mechanism, you can try to treat these kids conservatively with a cylinder class for 4 to 6 weeks. You can also consider a hinge knee brace that's locked in extension if you've got a more compliant kid, a kid you trust a little bit more, that, teenagers that's going to want to take the cast off and shower. Um, and then after that stage, we're going to start them with physical therapy with initially protected range of motion and gradually expand that range of motion. And with a gradual return to play protocol, they take about 3 months for full recovery. But most of these kids, you're going to have to refer over for orthopedics to get a surgical intervention before they start any treatment here. Up next, we have Osgood-Schlatters disease. So this is going to be our most common tibial tuberosity traction apophysitis. It's characterized by pain and swelling at that tibial tuberosity. It's going to occur generally around the ages of 9 to 14. Usually those kids are going to come in, they're going to have a rapid growth spurt. Um, Again, keep in mind that's going to be about a 2 year difference between our boys and our girls. So 13 to 14 on a boy, 11 to 12 in our girls. It is more common in boys, but we're noticing that gap is starting to close. And it is more common in our athletes than our non-athletes. So again, just like our SLJ, this is going to be our jumping sports, our basketball, our soccer, our football, our volleyball, where they're really contracting that quad tendon. Um, Physical exam, we're going to get pain at the tibial tubercle and pain with resisted knee extension. And sometimes you'll get swelling as well. On imaging, we're going to see that bony fragmentation at the apophysis. That's going to be pretty classic for apophysitis. But the X-ray helps us rule out, some non-misdiagnosis like a avulsion fracture, tumors, osteomyelitis. And these findings are usually going to be best seen on our nice lateral view here. So on our left image, we can see that bony fragmentation here. For treatment of these patients, most of them are going to do very well with non-operative management. They do not need to be totally shut down because it's going to be a low risk site for avulsion fracture. Um, but if they're having severe enough pain, they're like, Doc, it hurts when I just walk. I can't put any pressure on it. It's a time you might want to immobilize them for a short amount of time before you get them back into walking around school and then slowly doing some light jogging and then slowly progressing them back to their sports at that time. Um, Pain control with your anti-inflammatories, your Tylenols. You can use ice on top of it. And then these kids are also going to do well with that patellar strap brace, um, like your SLJ kids. Moving down to the calcaneus, we've got Seaver disease is next. This is going to be a calcaneal apophysitis. It's going to again be we're just this story of repetitive microtrauma to that ossification site by the Achilles tendon this time. It's usually going to be our kids 8 to 12 again. Um, it's going to be the most common cause of heel pain in kids this age, and it's more common again in males than females. These are going to be our planting sports, our soccer, and our gymnastics, and they're going to present pretty typically with that pain at the posterior calcaneal region. They might have a tight Achilles tendon. And when you do the squeeze test, which is when you're getting behind the Achilles at the calcaneal tuberosity and you're squeezing medial and laterally inward, they're going to have significant pain here. This is an example of our radiograph with the fragmentation again, of that apophysis. You might not have, again, for all of these diseases, it might just be a normal radiograph, so you might need to just diagnose it clinically as well. Management wise, these kids are also going to do pretty well without any operative management. Again, starting with activity modification, same story. If they're painful when they're just walking, you might immobilize them. But it's very rare. You're going to want to use these heel cups. So I took a picture of them here to help them have a little bit less pressure on that heel as they're walking. And then you can use an Achilles Cho-Pro strap, Cho-Pat strap, which can help take some of that tension off as well. And their physical therapy is going to be more at strengthening the core again, but directing their posterior chain so that they're having better energy transfer as well. These kids do very well and have low risk of long-term sequelae. Iceland's disease. So this is going to be traction apophysitis at the base of the fifth metatarsal. It's going to be from the repetitive contraction of the peroneus brevis tendon. And it's going to have pain in that lateral foot that's worse with activity. Again, improves with rest. No traumatic history. And It'll have pain with resisted eversion and extreme plantar flexion. Most commonly, kind of this nice age range, 8 to 13, after growth spurts. Um, and then these are going to be our ankle kids, so soccer, basketball, gymnastics, and dancers, people that are repetitively causing inversion stress. On our radiographs, again, we're going to see the fragmentation or the widened apophysis. Um, this is going to be a site where we're going to have multiple fractures that can occur. We can have avulsion fractures or Jones fractures at this area. So you're going to want to get a radiograph or an X-ray to make sure we rule this out. And then our MRI is just showing our bony edema here. Management wise, these kids again do well. Non-operative management, activity modification, slow progression back into play. Um, These kids do not often need immobilization, but you can use a cam boot if you need it. Again, NSAIDs and ice. As part of that, for the Iceland's disease, we want to make sure we're not missing a metatarsal avulsion fracture. These kids are going to come in with a sudden pop, a sudden pain, more traumatic, not a slow insidious onset, but it's our peroneus brevis tendon again that's going to be our culprit. Um, They usually happen at zone 1 of the foot, which is going to be different than a zone 2 or zone 3. We're going to see more of that Jones fracture. They occur more in all age groups, not just that nice 8 to 12 age group that you're going to see the Iceland's disease. They're going to present with tenderness, swelling, again, pain with that resisted foot eversion. These kids can be managed, or these athletes can be managed non-operatively if they don't have any rotational displacement of that avulsion. We can put them in a cam boot, and we're usually going to see that union by 8 weeks. Moving on to some osteochondrosis or some avascular necrosis diseases we might see for our kids, peds kids. We're going to start with Panner disease. It's usually going to affect our boys, about 90% of them from ages 5 to 10. It's very rare. Um, it's more common in athletes that have this repetitive valgus or axial stress at the elbow, so our baseball and gymnastics kids. And the most common idea is that it develops when vascular supply is insufficient for that continued stress on the achondroepiphysis during those compressive loads with the throwing motion. Like we talked about the counter traction between the rotator cuff and the or between the arm as it's stopping in that throwing motion, and then the weight bearing in the gymnastics when they're doing their tucks and their plants. On presentation, these kids are going to have significant lateral elbow pain, swelling, and limited range of motion, but they're not going to have that pop sound. There's not going to be a history of trauma. It's not going to be a sudden impact. They're going to have pain with pronation and supination at the elbow, with the elbow in full extension, and that's going to be called your radiocapitellar compression test. And then the findings are going to show fragmentation at that capitellum with an irregular joint surface. For these kids, it's a self-limiting disease, so a lot of reassurance for patients and their family. We're going to do pain control with ice and NSAIDs, and we're going to really just scale back on the activities that are causing pain. So they can go out and still run, jump, do all their cardio and conditioning, but just avoid anything that's actually loading on that elbow joint. Moving down to the lower extremity, we've got leg calf Perthes disease next. This is the avascular necrosis of the proximal femoral epiphysis. Usually presents with 4 phases. You're going to start with necrosis, which is the disruption of the blood supply, leading to damage to the subchondral bone at the femoral of the capital epiphysis, which leads to cessation of the ossific nucleus, and the infarcted bone soften and then dies. We then start to fragment this bone so it could be reabsorbed, and then osteoblastic activity takes over and the femoral epiphysis reestablishes, and then we get remodeling. This most commonly is going to affect some pretty young kids, about 4 to 8, mainly in boys, and it's about half to 5 kids in every 100,000 in the United States. Significantly favors males over females. And some risk factors include lower social economic status, living in urban settings, and being of Caucasian ancestry, as well as positive family history, low birth weight, and secondhand smoke exposure. So again, that secondhand smoke exposure is always a common part of our pediatric physical history taking. So good to keep that in mind. These kids are going to present with a painless limp that can be acute or more likely insidious onset. Um, if they are having pain, it may localize to the hip, but it can also radiate to the knee. On exam, they're going to have significantly decreased internal rotation and abduction at the hip joint. And their gait abnormalities are going to have two different stages. So acutely, they're going to have a short stance phase that's probably secondary to pain in that weight-bearing leg. And then chronically, as they get used to walking with a limp, they're going to transition to more of a Trendelenburg gait where that hip will drop. Image-wise, you're going to get an AP view and a pelvis view. The earliest finding will be just medial joint space widening, and due to the loss of ossification of the femoral head. You're going to get your crescent sign here. That's going to be best seen in this frog view. And then later findings are going to be a lower radiograph that shows the flattening or loss of that total femoral head here. We have multiple classifications for Legg-Calvé-Perthes disease, but the most common, most used one is the lateral pillar or the Herring classification. And we determine the staging at the fragmentation stage, which is about 6 months after symptom onset, and it's based on the height of the lateral pillar on the AP radiograph. So this is going to be how you determine who's going to do well with your non-operative management versus who you need to get over to your surgeon colleagues. So for our non-operative management indications are going to be your kids less than 8, they're going to have a skeletal age less than 6, and they're going to be in that lateral pillar A group, where the height is fully maintained and there's no density changes identified. They can use bracing or casting, but that's really hasn't been shown to be helpful. And then as long as they maintain that good spherical shape of the femoral head, they tend to have pretty good outcomes. Anything other than that, you're going to want to get over to our orthopedic surgical colleagues to make sure they don't need any kind of osteotomy here. Down towards the foot, we got Kohler disease. This is avascular necrosis in the navicular bone. It's going to be more common in our boys than our girls again. And kids are going to be usually 4 to 7. 25% of cases can be bilateral. They may be asymptomatic, but typically present with this dorsal medial foot pain. And then there's tenderness and swelling over the proximal midfoot. These radiographs, again, show flattening, sclerosis, fragmentation of the navicular bone. We're going to manage these kids non-operatively mainly, and they're going to be with NSAIDs, immobilized only if they have significant pain, but can also be immobilized with a removable walking boot or splint if you trust them. And then there's this study that was done that showed these three case studies that showed patients that underwent navicular decompression and circulation reconstruction after they failed conservative management and then had resolution of their symptoms 3 months after surgery and then did have normal bone density afterwards. And that was by Pei et al. In 2024. Freiberg's disease is going to be the avascular necrosis of the metatarsal head, most commonly at the second metatarsal, but can occur at the third and fourth less commonly. This one is finally going to favor our females than our males, and it's most commonly seen in our teenage years, 13 to 18. Again, dull, gradual onset of pain in the region of the affected head. Patients often describe the feeling of walking on a pebble, like a small irritant. There might be some swelling at the joint itself, and then pain gets exacerbated by motion at the joint. On imaging, we're going to see the subchondral sclerosis in early disease. As it progresses, you're going to get flattening of the metatarsal head here. And then in the late disease, we'll start to see some actual joint destruction. On MRI, you're going to get some significant bony edema, and you might even see some fractures in the metatarsal head itself. It's got a classification symptom or a scale to help drive management as well, based on its stage. So the Smiley classification with stages 1 to 2 will actually treat conservatively with a short leg walking cast or boot for 4 to 6 weeks. And then we can switch them to a stiff soled shoe. And then stages 3 to 5 will be more refractory cases, and we'll send those over for some surgical management. That is all I've got. Does anybody have any questions?
Nice job, Matt. That's a lot of stuff to go through, obviously, for just a 30-minute talk there. So I think you highlighted and um, a lot of the common conditions that you'll see in the pediatric athlete. So big things to remember. Um, is you're always getting, and then there's some debate about this too, but I think if there's any time of point of confusion, I always like to get contralateral films on these young athletes as well, just so you can ensure that the apophysis on the other side, there's no disparities between the two. But that's really kind of my one big bullet point there. Outside of that, yeah, it's a lot of stuff to remember, but for the non-op residents on, that's stuff you'll absolutely get tested on. Now, whether you need to know the eponyms, it's still always important, but from a clinical perspective as well, this is stuff you guys will see a lot with these adolescent athletes, and especially with overuse and sport specialization. Even though we made a concerted effort towards diversification for sports with our young athletes, it's still happening more and more. The travel industry still almost pigeonholes a lot of families into picking one sport at an earlier age and just focusing on that. So you'll see a lot of these overuse injuries.
Yeah. I will say for anyone on here that's a DO taking their Comlex or their DO boards here, they still use the eponyms.
Oh,
So,
they'll use eponyms everywhere.
yeah.
They'll definitely will, but at the same time, it's just yeah, it's my little plug of just naming the disease process and not the eponym. It's always better.
Hmm.
Any other comments or questions for Matt? Okay. Um, so I think Dr. Bridges was going to go next, but I think she's running a little bit behind from clinic. So I think Jill, if you don't mind, I think we'll probably have you go next if that's okay with you.
Hey, good evening. That's fine. I'm just sitting here listening.
That's awesome. Well, Jill is, oh, I've known Jill for a very long time. It's so nice and great of you to give this lecture for our residents and fellows. We're really happy to have you, and I can't thank you enough for it's a very, very important topic that's going to be pertinent for a lot of the people on this call. So I will let you take it away.
Hey, thank you. I Brandon, it's been a long time, so I appreciate the invitation to you and Dr. Fresh. So, for those of you that have never met me or don't know much about me, I have been a seasoned physician recruiter for 25 plus years. My parents put me out for childhood work, so I was really young when I got started. But a lot of my time over the last 11 years was previously spent there with the DMC, um, doing physician recruitment pretty much for all of the specialties, but particularly orthopedics. So I have a great amount of admiration and love for that specialty. Prior to coming to the DMC, I spent probably 14 years as the director of physician recruitment under the Ascension Health umbrella at Borges, and which is now Beacon Health. So, what I'm going to do, I'd like this to be open dialogue. It's obvious that all of you can read really well and comprehend really well. So what I'll do at the end is put a an attachment with the full presentation, and then that way you can take it with and go back through and look at any areas in greater detail that we may not have covered. I want to go by the outline that I gave to EJ, and the items that were listed consist of how to begin the search, the current recruitment climate, compensation, and resources. So, with that, I was able to do a little bit of fact finding. And let's see if I can share my screen here real quick. I'm not used to Zoom, I will say that. I'm more of a, if they've got me ingrained with Teams. So let's see here. I should be able to.
Yeah, I can maybe do the co-host, Jill, so you
There
should be
we
able
go.
to.
Are you
Yep.
able to see my screen?
No, we aren't.
Okay. I apologize for that. Well, then I'm just going to walk through and I can at least drop the document in the chat real quick, please. Just a
Let me see
second.
if you want to, I can pull it up. If when you hit that green share button, what happens? Because sometimes you have to go to your settings on whatever computer you're using and just authorize Zoom to allow you to share. And once that happens, it should be okay.
Okay.
Unless not, if that's, I'm gonna try to pull it up. Let me see.
I should have asked EJ if he wanted me to send this prior to. Just a second.
I guess the other thing is you can always send it to me. If you want to send it to me, I can pull it up.
Okay, let me see here. Quick. What's your email?
That's just bkakos at dmc.org. So bkakos at dmc.org.
Okay. Yeah, I think this is the first Zoom that I've had. Everything is now Teams, Teams, Teams. So just once.
Yeah, they're trying to do that with us too, but we're resisting.
Oh, I can see.
Right.
Let's see. Just 1 second.
Yeah, I was trying to see if EJ included it in the email, but he didn't. So
No, I didn't give it to him. I thought I would be able
oh,
to. Yeah,
okay.
just go ahead and share it. So let's see here. Hold on just one moment. Give me a second here because it's in a different format. There you go. You should have it. Did you get it, Brandon?
I have my email up here. It has not come yet. But if you sent it, we can wait to come. You can go ahead and just if you need to start talking, and I'll pull it up once it comes through.
That sounds good. So a couple things that doing some quick research between like in 2021, there was a press release by the AMA that projected a shortage of between 20,000 and 40,000 primary care physicians, as well as a shortage of 13,500 and 45,000 non-primary care specialties by 2036. So it just goes to show that the need for physicians, regardless of the specialty, continues to increase. And I'm sure you hear it all the time and you read it all the time. We project that each one of the residents and fellows that are in training. Each individual person will probably get contacted by 100 different physician recruiters in some sort. They might be working for a healthcare system, they might be working for an outside agency. So if your phone is starting to ring and your email box is getting flooded, that's an indication of where the needs are. And everybody is going after the same pool and population. In 2022, there was a predicted shortage of greater than 5,000 orthopedic surgeons by this year. Are you able to see the presentation?
Yes.
Okay, good deal, good deal. There we go. So this is the screen that I just spoke about. So I wanted to give you some insight on that. And then there are about 16 open positions for family medicine, sports med, and it's posted on a link on a site that's called Practice Link. And I have the link a couple of times in the presentation. So Brandon, if you want to share this, that'll be great. So what I
Yeah,
to
you want to
do
just, Jill, do you want to just let me know when you want to, because you can see the presentation, correct?
yes, I can, and I
Okay.
can advance. Yep,
So you want to just tell me when you want to advance it?
yep, I sure can. If you could please advance to page 9.
The survey recruitment contacts, that's 9.
Yes.
Okay.
Yep, that is correct. So I'm skipping through because I want to hit the meat of it so that I can allow for plenty of time for questions and answers. So when you look at the recruitment contacts, are any of you starting to get emails or anything from recruiters at this point? And you can just show with the wave of hands. And with those contacts, you want to figure out if they're coming from in-house, meaning a physician recruiter that's actually attached to an organization, or a physician recruiter that's from a medical group, a private practice group, or if they're coming from a search firm. Then your next question should be, what do they want? And why are they contacting me? Have an idea of what you want to do when it comes to an opportunity after you're done practicing, and that'll help you narrow down if you want to be bothered with those recruiters, because they will become newsome. So you don't want to have your time wasted, your e-box flooded. So when we look at timelines, if you could go to page 5. When do you start looking? When you start your search, you definitely have to allow for time for your license and for credentialing and relocating. Those are the 3 big pieces after you've decided where you want to go. Fellows typically begin their job search 1 to 2 years prior to completing your program. The market is competitive, as I've said before. Which is another reason to start early, because not only are there not as many physicians looking for a job, you want to be able to find the best job and not be left with something that you're not really interested in. If we have any individuals that are on a visa, please make sure that you start that process as early as possible. One thing with visa holders, particularly the J1s. This year, there are more opportunities for you to work in the USA. Before, it was typically a heavy focus on primary care, but now there is a HHS, which is a Health and Human Service application that you can apply for, and the timeline is much greater. Whereas with the Conrad 30 programs, they typically have to be filed by November of each year. They go by primary care first. They get priority, and then anything that's left will go to specialists. So with the HHS, we can use more specialists in filling those positions. I want to go to page 6. If you could go down, please. And assessment so that you can decide where you want to go and practice and the type of position you're looking for. Location is always a big deal. This should be a conversation between you, if you have a significant other that you're going to relocate with, so that you can decide together where you're going to go. If it's based on family support, or if it's based on you just don't want the climate where you're training and you want to go to a different weather pattern. So figure out your location and then look for the type of practice. Do you want to be in an integrated healthcare system? If you want profit versus nonprofit, there's a big difference between those two. Having worked in both of those settings, one of the big differences with the for-profit organizations, your earning potential is much greater. There's not as many restrictions on being compensated above the 90th percentile as it is with your nonprofit organizations. And it doesn't mean that if you're over the 90th in a nonprofit world that you won't be compensated. They just have to justify the means for extending that pay practice above that. Is it underserved area? If there are limited number of physicians within that specialty. So there are reasons for it, but make sure you have an understanding as to if you want for-profit versus nonprofit. And then you have private practice and academic. So just be honest, as I've got mentioned on the slide, and making your decision. I hear a lot of physicians, they'll say, well, it's not about the money, but at the end of the day, nobody works for free. So just be honest with yourself. You want to be happy as well as earning a good income. Make it the practice decision itself and the priority in your job search decision making. If you know as tempting as it might be to go to Hawaii for a job interview, don't waste their time and go there just to get the nice visit. And I think with COVID, some of my colleagues that do work in Hawaii, they've said that they have reduced the number of actual site visits to cut down on individuals just taking advantage of them. So one of the statistics that's on here is 72% of the physicians who put geography ahead of practice conditions start looking a lot sooner if geography is the most important for you. So just make sure you have a good idea of where you want to go. The other item that I want to mention is the fourth bullet point, and that goes with accepting a position where you feel included and not excluded from decision making, where you don't have that much of autonomy to express your concerns and to be a part of what direction your division might go and the effect that I have on you as a physician. So those are a couple of things that you want to make sure to keep in mind. The practice chemistry, have a look to see who the physicians are, do your research. I think that your world, to be so big, it's really small. I'm always amazed when I look at research projects particularly, and I'm able to see names of individuals that have collaborated together on different research projects. So go back into your black book of connections and call people and find out, is this a place you think I would be good to establish a practice? Continue to work with Dr. Keikos and Dr. Frush. They have been in the industry for many years, and I'm sure they have a wealth of connections to help you navigate those decisions. So I'd like to talk about the types of contracts because that seems to be a really big issue once you have done the site visit, you have interviewed on the phone with the recruiter. The recruiter will typically give you some idea of the pay range. So Brandon, if you could please advance to slide number 40 for me, that would be great. So, contract terms clauses. Most large organizations now work with a standard contract. There's not a lot of room for negotiating terms. There's not a lot of room to negotiate language. Their language is going to be standard. They're typically going to have the state of venue to be where that organization's home office is. So I know they're at the DMC. Their state of venue can sometimes be between Texas. There have been some in the past that have been able to negotiate that to have it be Michigan, but just have a really good understanding of what their status is and how they operate when it comes to the state of venue, because that basically means if there were to be a situation where you have to seek any kind of legal action, you'll know exactly what state they're going to operate those terms under. But you want to do your assignment in terms of looking at the contract. Always have somebody else look at the contract, and then also have your legal counsel look at the contract for you. I list at the end of the presentation that between myself and my team, we're here to help you navigate your contracts, to look at them, point out questions that you should ask. But you want to look at, items like such as the patient records, who owns them, and how, how's that managed. Of course, there's never language in the contract that speaks about their EMR, but have a good understanding of the EMR, because if you're on a productivity model of compensation, the billing has a lot to do with how the RVUs are collected, how they're tracked, which could have an effect on your productivity. So have a really good understanding of their billing system. Restricted covenants, that's probably one of the biggest issues. I have not seen any recent information as to what the final ruling may have been, if they are legal. There are some states that took it upon themselves to dismiss any kind of restrictive covenants. I know Indiana is a state that no longer has any kind of non-compete language in their contracts, and there are some others. Michigan, we're still somewhat up in the air. There hasn't been a final decision on that. You want to make sure you have a good understanding of their indemnification clauses, and then also their compliance when it comes to state, federal, and so forth. Have a good understanding of what the compliance policies are, And if there is ever a time when you have a question about it, what their protocols are, those items are not going to be explained as in depth in the contract, but as long as you have a good understanding of where to get the information and how that information is used, that will help. Then we have the medical staff membership. There will usually be language that speaks to whether or not you have to have um, medical staff privileges, even if you don't work in the hospital, if you're not going to be doing procedures in the hospital, it just comes a part of um, your employment within a medical group. And that applies to whether you're in a for-profit organization or a not-for-profit organization. So if you go down to the next slide, Brandon, when it comes to negotiating and closing the deal, you'll probably work with the physician recruiter for a large piece of this in most cases, unless it's a situation where the recruiter may not have the authority and the autonomy to help finalize that, in which case you would work directly with the CEO of the medical group or the head physician of a private practice. You want to make sure that all your questions have been answered. And if you can, as I mentioned before, please avoid going back with changes to the contract. If they use shall versus may, even though the words can mean different things, they're still somewhat in the same vein. So in most cases, you won't really win that fight. So stick to changes that are going to be most important for you during the time of that contract. Ask them to give you a reasonable amount of time for considering an offer. There's some organizations that will use a letter of intent, which is just to summarize, here's the position, here's the salary, here's the vacation, here's when you would start, and here's the commitment from us as relates to your CME, your vacation time, all the financial aspects. And then from there, you'll receive the full, totally embedded contract with those financial terms put into the contract. Do not accept a verbal offer, over the phone. Make sure you return the call and speak to the recruiter and give her that much respect. That's typically the highlight of our day when we get that call saying, yes, I want to move forward. And it's not official until both parties have executed. I have unfortunately been involved with situations where individuals have even received a letter of intent, and things happen and things could change. So just be mindful until both of you have signed that contract, it's not being considered as fully executed because the letter of intent is not a binding document. And then just make notes of the contract effective dates. With your start date, that can change. In most language, it will say there or about. So they understand that privileging takes time. And a lot of that is dependent on how fast the physician is able to complete their paperwork and their documents and to get their licensing for the state that they're going to move to work. So it's kind of a give and take on both sides. Now let's talk a little bit about compensation. So if you could go up to page 35, Brandon. There are many different pay models that are out there. Your work plus your RVUs, that's when you have a base guaranteed salary, and it can be anywhere from 1 to 2 years. You may find an opportunity that offers 3. A lot of that will be dependent on if you're establishing new and they really haven't um, had that particular specialty, but they, like for example, with the non-op sportsman, if you're going to a practice where the surgeons have done some of their own non-ops work and they decide we really need to have sportsmen non-ops join the group. So that might determine the length of your income guarantee. They want to give you time to ramp up. It's going to be new. You're coming out of fellowship training, so you'll need a time to adjust. So those models will typically be a base salary plus whatever productivity model they use. I am most recently accustomed in working with a model that will allow you to produce even during the time that you're on a guarantee. I have seen recently from some of my clients that they don't allow the physician to collect a productivity bonus during their guarantee period, but they're able to qualify for other forms of a bonus, be it a quality bonus that they put in place so that they're able to get something in addition to their base salary. Then I just spoke about the guaranteed salary. That means that you're guaranteed to receive X amount of money for X amount of period of time. There's the value-based compensation, and that's measured by some predetermined qualities and efficiency standards. I've typically just seen that more with family medicine physicians, primary care, that work for the value-based organizations such as I know Optum RX used to have the Optum division under United Healthcare. They used to have several clinics, and then there's Village MD, which has been bought out by Walgreens. So you typically see the value base under those scenarios. And then there is a hybrid, which is the mix of the base salary and quality bonus. And some of those quality bonuses can be paid quarterly as well as in the year. And then with private practices, a lot of theirs is based on net collection. So you're able to bonus, and that's, what's collected minus overhead and what's left. They can decide to do a withhold where you get 50% on a monthly or quarterly basis, and then the rest is put into a pot that you're able to receive at the end of the year. So can you go to the 36th page, please, Brandon? I've got some salary data, which I was really surprised because I have listed the 25th, the median, the 75th, and 90th, according to MGMA. And then there's a lot of the bigger organizations, they're using more of an average where they take a combination of MGMA, Sullivan Cotter, AMGA, and their own proprietary salary survey data to come up with a blend average for the 25th, the median, 75th, and 90th. And it's not uncommon, but at least you know where MGMA stands. They've always been considered the leader and behind that is Sullivan Cotter. AMGA, I think they typically lean more towards academia. They've been low in the past, but when I was able to get this recent salary data, I was really surprised that academics is, their salary data is there for their positions is far greater than that according to M2MA, but they're still using the same work RVU um, numbers. So that part has not changed. When you look at work RVU, the one thing that you'll want to pay attention to, and that's what they refer to as the conversion factor, and that's how much money you get paid in a dollar amount per work RVU. So you should be able to determine what your total work RVUs will be by dividing the number of work RVUs into the base salary that they offer, and that should come up to your conversion factor. But again, when you work for large organizations, they may have their own pay practice and pay model and hold you to the standards that they set for their organization. But this at least gives you a nice overview of the standard process that's used in terms of looking at the base and then looking at what the work RVUs are. And I was able to pull, like I said, for family medicine, sports med, as well as the same specialty, but in an academic setting. If we go to page 19, sorry, I got you flopping all around, Brandon. If you look at page 19, this again goes back to getting started and where's a good place to start looking for jobs. One thing that I'll say, if ever in doubt, pick up the phone and call any hospital, any medical group, any private practice, and ask to speak to the CEO or the head physician leader for the private practice group and let them know you're looking for a job. But at this point, pretty much all physician recruiters are listed in the career page of your large hospitals or medical groups. So you'll be able to get their emails and sometimes even their phone numbers so that you can reach out and to begin to explore if they have opportunities. Some people will say it should be listed on their career page, but to be honest, not all opportunities are current on the career page because that is an engine that is predominantly ran by human resources. So the physician opportunities are usually lumped within the general openings for the organization. So just to be sure, you can always call directly. I've given one other place down at the bottom, the AAPPR. That is our association for physician recruiters. That's where it's a national. That's where we are able to obtain our certification. So you can go through that and you can find the recruiter for a particular organization. And I would say in most cases, pretty much all physician recruiters are a member of that organization. They may or may not be certified, but they're a member. But career fairs are always a good place. Go visit them at the booths, see what their openings are going to be. I listed some specialty sites that you can also look at. We do a lot more online. job postings as opposed to actual in the journal. We just, it's proven that it's easier, I'm sure, for all of you to click open the journal online as opposed to carrying around the journal to read when you have time to do that. And then Practice Link and Practice Match and Healthy Careers are a great place to start, particularly for new grads. I receive probably somewhere between 10 to 12 emails every day from Practice Link. They provide me with all residents and fellows that have registered with their site. So they have opted in to say, I'm looking for a job. So when you do start to get those calls, it would be because of the physicians registering their information on Practice Link. But it's a good site. And you can put up some different parameters so that you can manage the number of calls and outreach that you receive. But it's a site that has been available, I want to say, since like 2000, 2002. So they just continue to get bigger and better. Practice Match is another good site. They work in conjunction with MedTies. So they might have your information whether you wanted to opt in or not. That's the only downside of Practice Match, but it's still a great place for you to look for an opportunity. And a lot of career fairs are starting to be available virtually. So you might say, I want to go get a job in Colorado. Practice Match, they do career fairs at least once a month in various locations. And they also offer virtual. So you could easily attend a virtual career fair without having to actually go there and meet with recruiters. So that's a very nice tool that you can keep in your toolkit for when you're ready to start that search. So those were the main things that I wanted to make sure to point out. The packet of information that Brandon has will give you more in-depth detail as it relates to common questions that you can expect from the physician recruiter. You'll typically have a 3-interview approach. It'll be the first call that will be scheduled with you and the physician recruiter. Then there will be a call with you and a clinical leader. And then the third will be an on-site interview. I highly advise and encourage you to bring your significant other or spouse, if you have one, when you get ready to go for your site visit, so that you both can see and get a good feel for the community, make sure it's someplace you want to go. When I first started with physician recruitment, it was considered to be successful if you could keep a new recruit for 5 years. Now, statistically, it shows that the average physician changes their first job within 2 years. So times have changed quite a bit. So take that person with you. We used to pay for kids, but that's not the case so much anymore. But they will, pay for you and your significant other or spouse to come along for the site visit. And then after that, you should be able to ask when you can hear further. What are the next steps, so that you just don't go to the visit and then leave and not really know what their process is in terms of letting you know of your of consideration and when you can expect to receive at least a letter of intent. Okay. Any questions? Okay. Brandon, if there are no questions, I think that will cover it.
Yeah, no, thank you so much. That's very helpful, especially for all the residents and fellows that are on here. It's a really invaluable talk that you just gave. And as long as you don't mind, I'm going to probably distribute your PowerPoint. Is that okay? Or would you
Yes, it
prefer?
is. Please
Okay.
do. Yep, please
Yeah,
do.
I think that'll be an immense asset for a lot of the residents, fellows, and honestly, even for any of us. There's a stat which I'm sure you can echo. You know, no one after graduating. You know, I think we leave our first job. 50% of the docs leave their first job in the first 2 to 5 years. So everyone is always potentially going to need this information, and it's very valuable. So I can't thank you enough for doing it.
You're welcome. You're welcome. And the last page of the presentation, it does have my contact number as well as my two staff, my partners, and I don't really even consider them staff. They're my partners. CJ is a well-established physician recruiter. She will be joining first week in December. CJ has spent most of her career between Covenant up in Saginaw as well as Mid-Michigan Hospital. So she's a great asset. I'm really fortunate to have her on the team. So between CJ and myself, we're here to answer questions for any of you. And then Christy is our assistant, and Christy's always helpful. If you can't get in touch with either one of us, Christy is another resource to make sure we get a message.
Yeah, that's great. That's perfect. Thanks again, Joe. Appreciate
All
it.
right, you're welcome. All righty.
Thank you,
Perfect.
Jill. Thank you so much.
You're welcome. Bye-bye.
Thank you.
Okay, I think our last talk is going to be Dr. Bridges. So Carla, sorry, I know we wanted to make sure we gave you enough time for your talk. That's why we kind of flipped the lectures there.
You know, I appreciate that. My apologies for running behind. So that actually worked out. All right.
Carla, Dr. Bridges, thank you very much for giving a talk today. When you tried to, I was in the same scenario you were. I was scrubbed in late. Case went longer than I expected.
Uh-huh.
I actually had the lectures on in the operating room in case I had to scrub out and whatnot. But thank you for being here. Dr. Bridges was a fellow with us several years ago, and very distinguished. She did both pediatric fellowship as well as a sports medicine fellowship with us. We were quite fortunate to have her here for this fellowship. I really enjoyed working with her. I probably learned as much from her as she did from us, and had a great opportunity to go to Palestine with her as well, and back several years ago. So anyhow, thank you for being here to talk with us.
Thank you so much for the invitation. Thank you for all those kind words. I really appreciate that. I'm trying to figure out how to share my screen on my iPad. So let me see if I can figure this out. The options I'm seeing, if anyone knows, I'm seeing screen, photos, share camera, iCloud Drive, website URL, and whiteboard.
Yeah, I don't know how to do it on an iPad. For us, it's usually there's like a green little arrow that says share. And I know Dr. Keikos did make you a host, so there shouldn't be an issue there.
Okay, let me see if it's. Let me try this now. So it can't be broadcast, right? Because that would that reflect back on me as far as like a image on me?
Broadcast.
I'm not familiar. I'm not even familiar with that. Let's see.
While you're looking, I'm gonna see if I can Google it.
Yeah.
I'm sure.
What were the buttons I was telling you have again?
So when I hit share, I see screen, photos, share camera.
So
Right.
it's screen, tap on screen, and then there should be a share after that.
So I'm looking, it says select screen and then tap start broadcast. So I guess it is
Oh.
broadcast.
Yeah, I see what it's saying. It's saying I need to enable do not disturb to prevent unexpected notifications. Oh, let me see. What is broadcast?
There we go. Starting to see something come up.
Yep.
Okay. Okay, I'm sharing my screen, but where's the option to open my PowerPoint? I don't see that.
Seeing it there, right? Okay.
So I do believe it just kind of just broadcasts your screen. So if you just go back to wherever like the application you were, you should be okay there. Yeah,
There we go. We're seeing
Okay.
there you go.
here we
Okay,
go.
so you can see it now. Okay, great. Let me just.
Correct.
All right, perfect.
Excellent.
All right. So thank you again for having me. So yes, as Dr. Fresh was saying, I was the sports fellowship class of 2023, and it was absolutely the best year of my training career. I absolutely loved it, and I hope you all are having the same experience. And yeah, the trip to Palestine was the highlight of that year. So I don't know if you all have that opportunity, but if you do, I would jump on it. I mean, I know I'm obviously right now is probably not the best time to go. Um, all right, so I'm going to give a talk tonight on ACL injuries and the skeletally immature athlete and the options for either repairing an ACL or reconstructing an ACL. And also, I'll touch on a little bit in regarding the repair. I'll touch on the Bear implant as well as briefly go over some information on supplemental LET slash ALL. Okay. So I have no disclosures, but in order to talk about an ACL repair with the Bear implant, I do have to mention the company that made it possible, which is Miak Orthopedics, but I have no financial relationships to disclose. So the goals for this talk, we're answering the who, what, when, and whys of pediatric adolescent knees in regard to ACL tears and how to treat them. So who gets these injuries? What surgical techniques can we offer them? Why? When do we offer them? And then why should we offer these specific techniques for these patients? So objectives are to review these patients who are more at risk, the rate of injury and reconstructions, preventative measures, review the natural history of this injury and timing of surgery for this population, and then how to choose a technique and a graft and a description of those techniques, and then brief information again over return to sports, ACL repair with the Bear, and the LET. So in 2008, there was an article that looked at the rise of ACL tears in the young athlete. ACL tears in the skeletal mature athletes, they were once considered rare, but now adolescents represent the largest per capita demographic of ACL reconstructions, as ACL tears are occurring at a much increased frequency in this patient population. And now they did report, though, there were fewer ACL reconstructions than expected during COVID. And there was a report where there was about a 30% decrease. And it's believed that the increased prevalence of ACL tears is due to multiple things. I think it's related to increased awareness of the injury due to improved examination and diagnostic measures, children and adolescents, increased participation in sports, increased pressure to participate at a higher level, starting at a younger age, specializing in one sport early, playing year round and on multiple teams, and it's just becoming more competitive for them over the past several years. So they're just more, at a higher risk now of injuring themselves. And the rate of ACL injuries in the pediatric population has been increasing at a rate of 2.3% for the past 2 decades in the US. And there was similar findings in a 2018 paper out of Australia and the hospital's San Antonio Allende in Argentina. It reported about a 200% increase in the rate of ACL reconstructions in patients younger than 18 years old. And a study published in 2014 reported a threefold increase in ACL reconstructions over the past 20 years in patients 3 to 20 years old. And in 2018, the Pediatric Information System, they observed that ACL reconstruction showed a 5.7-fold increase over 10 years. And they found that the peak age for ACL reconstructions to be around 17 years of age, and rates are about 15% higher in adolescent girls than in boys. And so outside of downhill skiing, female teen athletes who play sports that require a lot of jumping, cutting, and pivoting, such as soccer, basketball, and lacrosse, are at higher risk. And there's a few reasons why they believe that's the case. It's multifactorial. So females anatomically have more valgus knee alignment, putting stress on the ACL with landing or changing direction, which therefore would increase their Q angle. Possibly less muscle mass around the knee, limiting the protective effects. There's possibly a link between puberty and the menstrual cycle, and so changes in estrogen and progesterone levels may lead to changes in ACL laxity. And then there's also the thought of a smaller intercondylar notch width, as well as just a smaller size of the ACL in general. So prevention has been found to be helpful. So there was a 72% risk reduction found in athletes who are 18 years of age or less, and 16% risk reduction for 18 years or older. And there was this study here that kind of looked at different ways to prevent ACL injuries, and they actually did see a significant difference. So it's still important to still get athletes into whether it's let's say a center for the female athletes or physical therapy that maybe and their athletic trainers are well trained and are familiar with these preventative measures to try to prevent, of course, these injuries from happening, as they're very devastating. But when you have a skeletally mature athlete who has a complete ACL rupture, and you have to think about the different treatment options that you can offer these patients. And we know that ACL tears, again, in this patient population is very devastating because it really does take a significant amount of time away from their sports participation. And of course, but potentially and most likely will lead to some degenerative changes in the knee. So historically, orthopedic surgeons recommended postponing ACL reconstruction until patients reach skeletal maturity to avoid the risk of physeal damage and prevent growth disturbances. But things have changed. Clinical outcomes with athletes who were treated with non-surgical treatment or delayed ACL reconstruction and return to activity, they were associated with poor results, such as continued instability, meniscal and chondral damage, arthritic changes, inability to return to sport, and this can all have negative effects on the mental health. So there was one study that found that 61% of knees that were treated non-op developed arthritic changes. 94% were unable to participate at pre-injury level of activity, and 50% were unable to participate at all due to recurrent knee instability. So at this point, most people, if they have a young patient skeletally mature with an ACL tear, unless there are other factors as to why they may not be a good candidate for surgery, most of these patients are now receiving ACL treatment. And this was a meta-analysis that included 11 articles in 2016 by a group of athletic trainers. And their clinical question was, does early operative treatment of an ACL injury result in decreased knee instability compared with delayed or non-operative treatment? And their findings suggested that early ACL reconstruction will result in less knee instability and a more likely return to the pre-injury activity level without affecting growth plates or causing growth disturbances. In 2019, Dr. Shea and Dr. Ganley published a paper on the natural history of pediatric ACL tears, and they found that non-operative treatment for the skeletally immature athlete may be a viable treatment pathway for those who are able to comply with physical activity restrictions, and also could be considered in those aged younger than 14 years where there's an incomplete ACL rupture that's observed on the MRI and on physical exam. So they have a near normal physical exam. They also found that even with bracing and physical therapy programs, active athletes treated without surgery appear to have concerning rates of secondary meniscus injuries after the primary ACL injury event. And in this article here, this is a systematic review and meta-analysis of 30 studies published in 2021 by Dr. Coker in the Pluto study group. And it contained 50 cohorts that presented about 1,100 patients. And their clinical question was, is the optimal treatment strategy for ACL injuries in pediatric what is the optimal treatment strategy for ACL injuries in pediatric and adolescent patients? And they concluded that early and delayed operative treatment achieved satisfactory knee stability, but that delaying ACL reconstruction in pediatric or adolescent patients for 12 weeks or more significantly increased the risk of meniscal injuries and irreparable meniscus tears. And they also found that non-operative management resulted in high rates of residual knee instability and increased the risk of meniscal tears. And there was comparatively very low rates of return to sport. And the rate of meniscal or chondral injuries is 6% per month of surgical delay. So take-home message basically is that you don't have to delay surgery for our skeletally immature patients, because there are other options now to be able to perform ACL repairs or reconstructions in this patient population, and are safe and protective of those growth plates. So the reason for delaying surgery again in the past was due to that concern of physeal damage. And so the presence of open physes really increases the surgical complexity of ACL reconstruction in skeletally immature patients. So drilling across and placing bone blocks or fixation devices within the physes could lead to physeal bar formation, leading to potentially a physeal arrest, which therefore could lead to a limb that becomes deformed in a young child and ultimately potentially could need corrective surgery later. So granted, growth disturbances are uncommon. They're an uncommon complication after ACL reconstructions in skeletally immature patients. And some reviews have estimated the rate of growth disturbance to be as low as 1%, while other studies have described higher rates of deformity postoperatively. And this, of course, if you have a bad one, it could potentially lead to some serious consequences. So just kind of a reminder of what happens if you get a physeal bar. So a physeal bar along the side of the growth plate versus the center of the growth plate. So on the side, you can get a limb that could develop into develop an angular deformity. And if you have more of a central focal deficiency, you get more focal shortening. Both can leave an abnormal shape to the bone and can affect overall limb alignment, gait, potentially leading to some dysplasia, arthritis, potentially chronic pain. And angular deformities are going to be worse, usually if they get pretty severe past a certain degree. Patients may need some type of corrective surgery. And so techniques, again, for physeal sparing ACL reconstructions were then developed to try to prevent these complications. So a few risk factors for growth disturbance in regard to so there are a few risk factors in regard to ACL reconstruction. So one study, this one here, they found that the risk of growth disturbances generally increase with drill hole location, trajectory, and the proportion of the physis that is violated during surgery. And that drilling less than 5% of the physis is associated with minimal risk of growth disturbance. So central physeal drilling is associated with a lower risk of growth arrest compared with peripheral drilling, and vertical tunnels minimize physeal volume injured, but drilling vertically is also associated with continued rotational instability. So after an ACL reconstruction, so if you have continued rotational instability after an ACL reconstruction, that obviously could lead to a risk of re-rupture. So the image on the left, this shows you some of the different options and ways you can drill across the growth plates. So tunnel option A, that's the more vertical transphyseal drilling. So while it minimizes the physeal volume that's affected, it's less than ideal coverage of the ACL footprint and then a possibly continued rotational instability. Option B is more oblique transphyseal, and then this is more anatomic graft position for the ACL, but you're drilling through a greater volume of physis, which can have a negative effect on the growth plate. And then option C is a more horizontal epiphyseal. Nice thing here is that you try to keep near anatomic position of the ACL. You're not drilling through the physis, so it's protective of the physis. But it does require precise tunnel placement to reduce the risk for physeal damage. It requires radiation because you need an X-ray in order to do this to confirm that you're in the right spot. It can be technically challenging, and you can still cause harm to the growth plate if you're too close to it from the heat from the drill. This systematic review published in 2021 from Dr. Coker and the Pluto study group again, wanted to comprehensively describe how previous studies in the pediatric ACL literature have assessed preoperative skeletal maturity and remaining growth potential, and to review the incidence reporting and monitoring of postoperative growth disturbances. So this study included 100 articles and about 3,800 patients. And they found that 2.1% of patients demonstrated a leg length discrepancy of greater than 10 millimeters from the contralateral extremity, and 0.5% of patients had a discrepancy greater than 20 millimeters. And that's around the point where some people with leg length discrepancies may start to become symptomatic or notice it. And a lift may be able to correct it, but it might start getting a little uncomfortable wearing a lift that's larger than that. 0.6% of patients underwent growth modulation procedures for treatment of leg length discrepancy. The femur was involved 83% of the time. 1.3% of patients demonstrated a postoperative angular deformity of 5 degrees or greater. And majority of patients who developed angular deformities, they underwent a femoral or tibial transphyseal technique. Femoral valgus was the most common deformity, followed by tibial recurvatum, and then tibial varus. And so that makes sense when we think about where we potentially get those physeal bars. So if we rest on the out or the more lateral aspect of the femur or the femoral physis, we could go into more of a valgus position as the medial physis will continue to grow while the lateral is halted. Same with the tibial recurvatum. If we damage the tibiocervical apophysis, if that is harmed, you may get some recurvatum there, and as well as the tibial varus, you go more medial. If you get a physeal bar on the medial side of the tibia, your lateral tibial physis will continue to grow, and you go into more of a tibial varus deformity. And 0.4% of patients underwent growth modulation for treatment of deformity. So before performing the surgery and to help determine the best technique to use, documenting the sex of the patient, assessing skeletal age, and calculating remaining growth should be performed for children and adolescents with open growth plates. And this is most frequently assessed using a PA radiograph of the left hand to get a bone age, but there are alternative methods. You could use the pelvis, the elbow, calcaneal radiographs. Some surgeons use timing of peak growth velocity, which can be derived with Tanner staging, as well as time since menarche for females. It is also important that you look for and document pre-existing length and angular deformities. So something I'm trying to remember to do in my practice is if I'm going to treat an ACL that in a patient who's skeletal mature, is trying to get leg length films pre-op so I can compare them to them post-op if I'm concerned about them developing a deformity. And this can be done as like I mentioned, hip to ankle x-rays, scanogram if need be. If you have an EOS machine, even greater, because it just kind of scans the body and it's less radiation. So while the Grulich and Powell Hand Atlas has been the gold standard for a bone age assessment tool, the Sanders maturity scale or RISR staging, which is actually more commonly used with scoliosis, is an option as well. And this is a knee MRI bone atlas or bone age atlas that was created to try to circumvent the need for that left hand X-ray. So it's like you already have the MRI. Maybe we could just use this MRI instead of X-raying another part of their body. And so this atlas was found to provide a simple and efficient way of assessing the skeletal maturity of adolescent patients, and had inter and intra observer reliability equivalent to or better than the standard method of utilizing a left-hand X-ray. And then also remember how to predict the amount of growth left using the estimation technique with the rate of growth from around the knee every year until skeletal maturity. So once you have skeletal age, then what do you do next? How do you determine which is going to be the best technique for these patients? So something that's helpful is just remembering the average of when girls and boys reach skeletal maturity. So skeletal maturity occurs around age 14 in girls and age 16 in boys, but there is a small amount of growth remaining around the knee after age 12 to 13 years in girls and 14 to 15 years in boys. And around those ages, there's about less than 1 centimeter of growth remaining in each limb segment. So for patients who still have a significant amount of growth remaining, so like a Tanner stage 1 to 2, bone age 12 or less in boys, 11 or less in girls, one can still consider non-op treatment if it's in an appropriate patient, but for most, you would consider using a physeal sparing technique with either the IT band combined extra intra-articular technique or an all epiphyseal technique. Would have to be all epiphyseal on the femur and the tibia if there is adequate bone stock. And oftentimes in those younger patients, there's not enough bone stock to comfortably get a tunnel, usually through the proximal tibia. And the IT band is is a little bit easier to do because then you don't have to worry about potentially getting too close to the growth plate. And so for children with little growth remaining, Tanner stages 3 or greater, skeletal age 12 years or older in females and 13 years or older in males, one could consider a physeal respecting technique. So placing tunnels kind of in a more vertical position to try to decrease the physeal volume affected, using smaller tunnel sizes, using a soft tissue autograft, and avoiding transphyseal fixation implants such as interference screws, and also no bone blocks. And I would not use a BTB in a patient who still has open growth plates, and that's for multiple reasons. You have the distal femoral and proximal tibial physes that are still open. The tibial tubercle apophysis is still open, so you don't want to harvest from there. Same with the inferior pole of the patella. Its growth center is not fully developed. You could also consider a partial or a hybrid transphyseal technique if the patients have less than 2 years of growth left. So you can be all epiphyseal on the femur, but transphyseal on the tibia. And then some people will still do more of like an adult technique, all transphyseal, even if the growth plates are open, if there's 2 years or less of growth remaining, but still practicing more of a physeal respecting technique is ultimately just better practice. And the transphyseal ACL reconstruction with the soft tissue graft with bone blocks and transphyseal fixation is, again, more appropriate for adults or skeletally mature patients. This is just another algorithm that was created to help choose the best technique depending on sex, Tanner stage, and bone age. So again, there are various physeal sparing and respecting techniques with a variety of tunnel methods and approaches for fixation. And so this is a list of some different types, and I'm going to try to cover most of these. And this is just a visual of some of those techniques that I believe is on the AOSSM website. And this is also an article I found to be very helpful in determining best ways to treat this patient population because it really covers a lot of the methods that I'm going to mention today and also a lot of the information that was discussed. Okay, so video is playing for you all.
Yes, but
Yes.
can't hear it.
Okay, yeah, there's no volume. That's okay. Okay, so this is a physeal sparing ACL reconstruction. This was first developed in the 1970s and was described in the literature in the early 1980s, and many have been modified over the years. So this particular technique shown here, this is Dr. Coker. He's showing the combined, combined extra and intra-articular ACL reconstruction using the IT band as an autograft. This was developed by Dr. McIntosh in the 1980s. And later modified and popularized by Dr. McKaylee and Dr. Coker in the early 2000s. And so this procedure is primarily indicated again for patients who Tanner stages 1 to 2 have wide open physes, mean age of 10 years, and also for patients with small bone stocks and all epiphyseal techniques are not adequate. And so advantages: no tunnels needed, which means you completely avoid the physis. This improves the ease of revision surgery if needed because there are no previous tunnels and all other autograft options remain intact. And sorry, my screen froze. Okay, I'm back. Okay, so, and one of the nice things is that when you're doing this technique, you are basically creating that additional extra-articular reconstruction limb, similar to an ALL or an LET, because you're bringing that that over the top position. And it's the IT band. You're kind of bringing that over the top position. So it's almost like you're also doing an LET. Now the disadvantages, it's a non-anatomic configuration. But biomechanics studies have shown that restoration of kinematic constraint and good clinical outcomes with lower vision rates at a mean 5.3 years. Another disadvantage is that the IT band autograft can tether across the growth plate stills over the lateral distal femur and proximal medial tibial growth plates, and this still can put a limb at risk of developing an angular deformity just from the tethering alone. And this has been described in case reports. And so it's just something to think about, but still probably a better option than, drilling across your growth plates, as that complication is very rare. So this is the surgical technique article that describes this technique in detail. And in this procedure, the central 1/3 of the IT band is harvested proximally and left attached to Gerdy's tubercle distally. And that's going to be the extra articular portion of the procedure. The graft is then brought through the knee and an over the top position posteriorly and passed under the intermeniscal ligament anteriorly on the anterior aspect of the tibia. And that's the interarticular portion of the procedure. And so the images here show the IT band being passed into the joint, into the intercondylar notch, and then passed below the intermeniscal ligament. And then a trough is placed under the intermeniscal ligament to allow for a more anatomic graft placement. And you try to do this though without causing harm to the physis. So obviously you don't want to go too deep with that trough. And so here he's creating that trough, and then he's going to bring an instrument back in to grab the sutures that are attached to the IT band, and then he's going to bring the instrument he's which looks probably like a Kelly. He's bringing that in and going underneath an intermeniscal ligament, and then he brings the graft out anteriorly. And we'll fix that in place over the anterior tibia. And so that's a picture of the graft there after it's been passed. And so proximally, the graft is then fixed with sutures at the insertion of the intermuscular septum and the periosteum of the lateral femoral condyle with the knee in about 90 degrees of flexion. And then distally, it's fixed to the joint. It's fixed distal to the joint. So the graft is sutured with usually like a heavy non-absorbable suture to some periosteal flaps. So you'll kind of create periosteal flaps, bring the graft down between those flaps, lay the flaps over, and then you suture the graft to the flaps, the periosteal flaps. And this is done with the knee in about 20 to 30 degrees of flexion with a reverse Lockman's or reverse Stror applied to the knee. And this is what it looks like on the MRI post-op. And then this is Dr. Koger's post-op protocol. So next I'm going to describe the all epiphyseal tunnels technique with different femoral and tibial fixation options. This technique was first described by Dr. Anderson in 2003. It is an anatomic ACL reconstruction technique, and historically the graft of choice was a 4-strand hamstring autograft that was secured by means of a suspensory fixation on the femoral side and a screw-in post on the tibial side. And typically it's performed in pre-adolescence with open femoral and tibial growth plates, so Tanner stage 1 and 2, mean age of 13, and have sufficient epiphyseal bone stock in the femur and the tibia. And so in this video, this is Dr. Edmonds from Rady Children's in San Diego. And the video is demonstrating this technique with an all epiphyseal interference screw for fixation in the femoral tunnel and suspensory button for the tibial fixation. And the images show femoral fixation with an all epiphyseal physeal sparing suspensory button, and then a screw-in post on the tibia. And then for this technique, you do need a C-arm to ensure that you're not violating the physes. And so bony tunnels are drilled to attain proper graft position and fixation, and the femoral tunnel is drilled horizontally in the distal femoral epiphysis in a lateral to medial fashion, and ending in hopefully in the proximal aspect of the ACL footprint. And then the tibial tunnel is drilled in the proximal tibial epiphysis in an anterior to posterior and inferior to superior fashion, staying within the tibial physis, again, using x-ray to confirm that. And of course, so we can avoid the growth plate. And in this image, a hamstring graft is secured on the femoral side with use of a cortical button. And on the tibial side, a screw and post is placed anteriorly and just distal to the tibial physis and medial to the tubercle apophysis. So important to stay medial to that tubercle apophysis to not avoid that. I mean, so to not violate that. And the graft is passed through the tunnels and tensioned to the post with the use of suture tags. And here he's tensioning the graft and then checking range of motion, making sure there's no impingement. And on final x-rays, we can see that screw post, and in this case, it's a different button device there on the femur. And so studies have indicated a mean IKDC score of 96.5 with no clinically important growth disturbance when patients were followed to skeletal maturity, and that mean follow-up was about 4 years. There is some concern that the tibial fixation may distribute a tethering force across the physis, which may result in increased likelihood of distorted physeal growth, very similar to the IT band. And this technique is very similar to the last, but where bony fixation with either an interference screw or cortical buttons are used, but are confined to the epiphysis and do not cross, tether, or violate the growth plates. So in midterm to long-term outcomes of patients who undergo ACL reconstruction with all epiphyseal tunnels and fixation are lacking, but one study showed no evidence of growth disturbance in any of the patients during short-term follow-up. This study by Dr. Ganley and Dr. Wells, published 2017, looked at the early complications seen with this technique. There were a total of 103 patients retrospectively reviewed in the study with a follow-up of 21 months. The overall complication rate was 16.5%. There were 11 re-ruptures, about 10.7% re-ruptures. There was less than 1% of clinical leg length discrepancies of less than 1 centimeter. There were 2 cases, or about 1.9% of arthrofibrosis requiring manipulation under anesthesia. 2 patients sustained contralateral ACL ruptures. About 3% sustained subsequent ipsilateral meniscus tears during the study period. And knee flexion continued to improve by 20 degrees on average between the post-op week 6 through 6 months. And they concluded that all epiphyseal ACL reconstructions in children are safe. The rate of growth disturbance is similar to previous reports in this patient demographic, and the re-rupture rate in this cohort is slightly higher compared with ACL reconstructions in older patients. And the X-ray here on the right shows a partial transphyseal or hybrid technique, and the image on the left shows a physeal respecting technique with less horizontal tunnels across the physis, soft tissue graft, and suspensory fixation on the femur, and interference screw on the tibia that is not crossing the growth plate. Both may be appropriate in older children whose physes are still open but have less than 2 years of growth remaining. And such hybrid techniques, you're gonna, so as far as the all epiphyseal portion, it's gonna be all epiphyseal on the femur and transphyseal on the tibia. And that's because the femoral physis, you get more growth from the femur over time, and you don't want to violate the femoral physis if possible. And typically bone stock in the distal femur is much more robust, much bigger, wider space for you to work with, versus the tibia. It's much more challenging. And this article, this was published by Dr. Wilson in 2018 and reported on outcomes of 23 hybrid ACL reconstructions in patients with an average bone age of 13 years. And they reported an average IKDC score of 96, and that 2 patients developed a leg length discrepancy. All right, so remaining growth also is influences the graft selection. So depending on if their growth plates are open, that's going to help me decide. I mean, right away, I know I'm not going to offer them a bone tendon bone, but then I have different soft tissue grafts I could offer them. So graft choice is still, controversial topic. A soft tissue autograft is typically chosen for a skeletally immature patient, so hamstring, quadriceps without the bone block. IT band, of course, for the very young patients. An allograft is typically not a great choice in this population, as the failure rate is 3 to 4 times greater than an autograft. So I will bring it up, but I tell them that it's not something I don't recommend it. And BTB not used in the skeletal mature patients, as the tubertubercle patellar ossification centers are still open. Bone blocks across the physis should be avoided. And so the tubertubercle ossification center appears at 11 to 14 years of age and fuses in early adulthood. And the patella ossification center appears at 3 to 5 years of age and fuses at around puberty. So a little bit of information on returning to sport. So this study published in 2017 looked at 42 skeletal mature athletes who underwent ACL reconstructions using an ipsilateral hamstring tendon autograft, either with an all epiphyseal or partial transphyseal technique. And the mean time for return to unrestricted competitive activity was 12 months. 93% of athletes returned to their primary sport, 83% returned to unrestricted activity, and 4 athletes re-injured their ACL, 2 injured their contralateral ACL. And there was a study by Dr. Kay in 2018 that reported 13% graft rupture and 14% contralateral tears in a similar patient population. For those interested, the Pluto group, or the Pediatric ACL Understanding Treatment Outcomes group, this is an ongoing study. It's a multi-center study, prospective cohort study that's collecting patient-reported outcomes and radiographic data, non-operative treatment, and several different ACL reconstruction techniques. They go over all of this on their website. It's if interested, I think it's just Pluto. I think it's it's at the bottom there, plutoacl.org. And then the Moon group is also another great resource. It's it can be found online at acltear.info. And they actually have a risk of re-injury calculator. Okay, so some information now on supplemental LET or ALL procedures. So the anterolateral soft tissue structures of the knee, they've been shown to contribute to anterolateral rotary instability. And persistent anterolateral rotational instability of the knee is associated with worse functional outcomes in patients who have undergone ACL reconstruction surgery. And this is typically measured with pivot shift testing or patient describing repeat episodes of instability. So persistent anterolateral rotational instability may persist in up to 20% of patients after an ACL reconstruction. It could be due to a variety of reasons. It could be damage to posterior medial, anterolateral, lateral, or posterolateral structures. It could be damage to the meniscus. It could be that they had an increased posterior tibial slope. And so that's why this procedure, whether a lateral extra-articular tenodesis or an ALL reconstruction, that's why they were developed. And originally it was created potentially to treat ACL tears, did not have good outcomes, but now it's being used to augment ACL reconstruction and to aid in restoring that anterolateral rotational instability, or restoring stability and prevent that anterolateral rotation instability that some patients may continue to have. And so prior to the development of intra-articular ACL reconstruction, it was used as an attempt again to restore normal knee kinematics. But again, that did not work out so well. So then they kind of scratched that. They went to ACL repair, that didn't work. Reconstruction, that worked really well. And then LET kind of came back when they realized that maybe we can add it to the ACL and it could improve our outcomes. And that's what the data is showing so far. So there are several described indications for LET in the literature. So it could be high-grade pivot shift. I've seen some papers describe it as a grade 3 or grade 2 or higher. Young athletes, so 25 years younger, have a desire to continue playing high-risk sports, so pivoting, cutting, jumping. Patients who may have some generalized ligamentous laxity, so a Beighton score that's elevated. I've seen papers described as anywhere from a high Beighton score to them being 4 or greater. I've seen some say 6 or greater. Knee hyperextension greater than 10 degrees. Patients having a Sagan fracture seen on X-ray. A chronic ACL tear. Radiographic lateral femoral notch sign, lateral coronal plane laxity, and more oftentimes being used in a revision ACL reconstruction. And there's no consensus within the field for indications for LET augmentation for ACL reconstruction at this time. So it's important to really have a clear understanding of the indications. And a lot of controversy exists regarding the clinical effects of LET procedures because of the potential concern of increased pain, morbidity from the procedure, as well as lateral compartment overconstraint, potentially leading to OA within the lateral compartment. And more recent literature has demonstrated strong clinical outcomes for arthroscopic ACL reconstructions with concomitant LET, showing an added benefit of less rotational stability. And this was a multi-center study, a randomized controlled trial by Dr. Getgood, and showed a significant decrease in graft rupture rate when ACL reconstruction with a hamstring. So this study only looked at hamstrings. With hamstring autografts, when those were combined with the LET, and then were compared to ACL reconstruction with hamstrings alone. And so 45 patients experienced graft rupture, 11% were in the ACL reconstruction group alone, compared to 4% in the ACL plus LET group. There was less pain seen in the ACL reconstruction group alone. There was no clinically important difference in patient-reported outcome measures. No clinically important difference were found in either group at other time points. Level of sports activity was similar between groups at 2 years after surgery. And future study is now underway, the Stability 2 study, which is going to look at BTB and quad and comparing solo BTB and quad ACL reconstructions to BTB and quad with an LET. So this is the LET technique. Basically requires a distal lateral femoral incision over the IT band. If you do a inside out or all inside technique for your femoral tunnel, you usually are already going to have a small incision there, so you can extend that down towards Gerdy's tubercle and dissect out the IT band. And then you just need kind of the lower posterior portion of the IT band. You're still going to leave a little cuff intact, so it helps with the closure. But you just need about 1 centimeter width, and as far as the length, about 8 centimeters from Gerdy's tubercle. I still take a little bit more because I've had some that were a bit short and I had a hard time getting it up to its fixation point. So I think taking a little bit more is probably okay, just so you don't run into that. And then once you reflect that down, you palpate and you can feel the lateral collateral ligament pretty well, and you feel the anterior and posterior border, and you safely pass dissect around that and pass a curved clamp or right angle clamp around the back side of that LCL. And of course, you're going to have your graft prepped usually, by this point, and you just need about 2 centimeter length of a whip stitch. Pass that behind the LCL. And your fixation point is going to be just proximal and posterior to the lateral epicondyle. And this is the part that can get kind of tricky because you want to make sure that you don't converge with your femoral tunnel for your ACL. So one way you can confirm that is after you've drilled your tunnels, but don't pass the graft yet, you can actually bring your camera in and look up the tunnel. And as you drill for your LET, just make sure you're not, converging with your femoral tunnel and adjust as needed. And usually if you just aim slightly proximal and anterior, you can stay away from your femoral tunnel. And if you do an onlay technique, then you don't have to worry about it as much. And so once you have that fixed in place, when you fix it in place, you're going to want to put the knee at 30 degrees flexion and keep it in neutral rotation. And now some information on the ACL repair with the Bayer implant. So Bayer stands for Bridge Enhanced ACL Restoration. It was approved by the FDA through the De Novo pathway in 2020, and it was created to provide the healing properties necessary to help the native ACL tissue heal. And the idea is that it's providing that healing scaffold for the ACL to heal into. And the reason why the torn native ACL cannot heal on its own is because of its poor blood supply and the inability for the knee to maintain a well-organized clot after the tear due to the synovial fluid in the joint. So it's a volatile environment for the blood clot. It is constantly getting washed away. And so that's why our ACLs don't really heal that well after they tear. And so the Bayer implant is a bioactive scaffold that simulates an organized clot to provide the bridge needed between the torn ends of the native ACL and to try to facilitate a repair. And the procedure is an arthroscopically assisted one that involves combining a method of suture repair of the torn ACL stump and the Bayer implant technique. And it requires a small arthrotomy to implant the device after the ACL tibial stump has been sutured. And ACL tears are often treated with ACL reconstruction, where the torn native tissue is replaced with graft, either an autograft or allograft. And this has been found to be an effective procedure, but of course it has some drawbacks. So allografts have been found, and allografts also found to have a high rupture rate, especially in this young patient population. And with autografts, there is donor site morbidity and possibly prolonged weakness due to violation of tendons and other soft tissues. There are more and possibly larger incisions involved, and a reconstruction leading to more scars and possible sites of infection. In a reconstruction, you are required to drill larger tunnels, leading to larger holes in the bone, which could lead to challenging revisions. And in general, ACL reconstructions are technically more challenging, several tedious steps, which all require some troubleshooting if they do not go as planned. And so the implant is specifically, it's a bovine-derived type 1 collagen that is decellularized and has no chemical cross-linking agents and create so that it can't create an extra cellular matrix. I'm sorry, that is to help it create an extracellular matrix. So it's a cylindrical shape, about 4.4 centimeters in length by 2.2 centimeters in diameter, and it was designed to be hydrophilic to easily absorb a patient's own blood, and that encourages it to clot within the Bayer scaffold. And preclinical studies on animal subjects showed that cells permeate through the scaffold within 1 week of implantation, and that those cells remodel the Bayer material, which is completely resorbed by 8 weeks after surgery, but leaves the healing scaffold behind. So the Bayer may be gone, but the healing properties have stayed behind. And preclinical studies also revealed a lack of synovial or inflammatory response due to the reduced bovine DNA content in the scaffold. And as the implant absorbs the patient's own blood, it holds onto the platelets, red blood cells, white blood cells found in whole blood in the wound site of the torn ACL tissues, allowing those cells to stimulate the ligament cells around them to invade the scaffold and regenerate the injured ligament tissue. The scaffold can absorb 5 times its weight in blood, and as it does so, it softens and conforms to aid with implantation. And so this is a list of indications and contraindications when it comes to selecting patients for the Bayer procedure. This has changed over the years. They have changed their indications. Initially, there was an age cutoff. The ACL tear couldn't be older than, I think it was like 45 or 50 days. I thought, I remember reading 50 days on one paper. It had to be isolated ACL tear, no multi-lig, no meniscus tears. Initially started in athletes, in patients who were non-competitive athletes, and eventually it's been now the indications are for competitive athletes as well. And so, all this information can be found on the MEAC website. We're going to skip over the video just because we don't have time. So there's several advantages for using the ACL repair Bayer technique. So you don't have to harvest an autograft. So there's no donor site morbidity. There's no need for human donor allograft tissue. You could possibly avoid prolonged weakness that you may see with the reconstruction. And it is a fairly easily reproducible procedure. And it has now been indicated for a broad range of different type of ACL tears. So initially it was just mid-substance. Now, honestly, you could probably have a little piece of tissue left and they'll say it's okay to use it. It avoids several of the tedious steps required in reconstruction. It does not require large tunnels, therefore it's bone sparing. And a revision of the Bayer procedure to an ACL reconstruction is feasible and has better outcomes when compared to a revision ACL reconstruction. Some of the disadvantages when it comes to recovery and rehab, it's still the same average time to return to sport as an ACL reconstruction. So it's still average 9 months, it could still take up to 12. Returning to sports sooner, around 6 months, has been shown to have a higher re-rupture rate. When placing the blood on the implant, it really softens and becomes mushy, and it makes passing it in the joint difficult and really messy at times. And that's why it does require that arthrotomy to really open that space up to pass. Implant is expensive. For what I could find online, the price ranges anywhere from 5,000 to 15,000. You do not get the immediate stability that you would with a reconstruction, depending on the ACL, the type of ACL tear. So you have to be patient. You have to wait for it to heal, wait for that disability to come over time. And if it doesn't heal and the patient continues to have instability, it could require revision to an ACL reconstruction. And then, the average 9 months of recovery will start over, which means patients could miss more sports. They could miss up to 2 years of sports. And therefore, proper patient selection is key. And oftentimes it can be really challenging deciding on who the implant is best suited for. Not all ligaments can be repaired. Therefore, you have to be ready on day of surgery to potentially switch to a reconstruction. So you should have that conversation with your patients and consent them for reconstruction still, because you may get in there and realize there's no tissue left that you can repair. And the Bayer rehab protocol also is slightly different than the ACL reconstruction protocol. At least in the beginning, it tends to be a little bit slower to start. And then it's also kind of confusing, like the wording. And so I kind of noticed that my patients who have actually had follow the Bayer rehab protocol, I didn't like their movement in the beginning. I thought they were moving slower than my ACL reconstruction patients. So we've made some changes to that. It's contradicted in patients who have bovine allergy, and there have been some reports of increased postoperative stiffness after the Bayer implant as well. So early results of the Bayer procedure, they are promising. In one of the earlier studies, researchers demonstrated no failures in the Bayer group after 3 months. And then in the first prospective randomized control trial with 2 years of outcome data, there were findings of 14% failure rate at 2 years compared to 6% in the ACL reconstruction cohort. And this was not statistically significant. 8 patients out of 65 who received a Bayer were revised to an ACL reconstruction in the 2-year study. Research showed that laxity following the Bayer procedure was nearly equivalent to 33 hamstrings and 2 BTB ACL reconstructions, and that hamstring strength was significantly higher in the Bayer group compared with the ACL reconstruction group. And the failure rate for Bayer was highest in patients aged 18 and younger, which is also seen with ACL reconstructions. Range of motion was nearly the same at 2 years. And longer-term results are needed to determine whether the procedure helps reduce the rate of post-traumatic arthritis and determine return to sport rate and level of play. There are currently 2 active studies, the Bayer 3 and the Bayer Moon. So the Bayer 3 is a multi-center study where all patients received the Bayer implant to treat their ACL tears. The enrollment ended in 2023, and patients are going to be followed for 10 years. The Bayer Moon is an NIH-funded study and is comparing traditional ACL reconstruction with a patellar tendon autograft to the ACL repair Bayer implant procedure. And so 200 patients are in the study, ages 18 to 55, and will be randomized to receive one of those treatments. And ACL surgery has to be within 50 days of the tear, and the patient's BMI has to be less than 45. And so repair failure is determined by a positive pivot shift exam, but grading C or D, Lockman exam with greater than 6 millimeters side-to-side difference, absence of tissue, and expected ACL location on an MRI after you've given it some time to heal. And it can take up to 2 years for Bayer's implants to heal in fully. And then symptomatic instability requiring revision ACL surgery. So, in summary, who are we thinking about when considering alternative ACL reconstruction techniques? That's going to be the skeletal mature athlete. And what do we offer them? A fascial sparing or respecting technique. When do we offer it to them? I think a safe way to decide this is if the athlete is greater than 2 years or has greater than 2 years of growth remaining, then a physeal sparing technique should be used. And it is also important to look at bone stock. And if you're thinking about all epiphyseal techniques, or you can use an IT band. And why do we perform these techniques to prevent growth disturbances? Thank you. Any questions?
Yeah, Dr. Bridges, that was an outstanding technique, which I thoroughly enjoyed. Thank you very, very much.
My
And
pleasure.
I enjoyed listening about the bear as well, which we've been doing. My understanding with the bear was I think the FDA recently lifted the 14-year-old restriction that now any peds is a candidate for the bear. Is that your understanding as well?
That's my understanding. That is
Okay.
correct. Yeah.
Okay. I thought I had heard that recently.
Mhm.
I had so two questions. One was regarding the over-the-top procedure. Is there any indication for that? Today with the physeal sparing techniques that you talked about. The reason I ask is I've had a few really young ACLs here in the last year, an 8-year-old and a couple of 9-year-olds, 2 males and a female. I think they were all trampoline injuries, and I think we're probably seeing more of these young patients because of the trampolines. They're not necessarily sport related, aside from trauma from the trampoline. And on all 3 of them, I chose an all epiphyseal technique. But would you feel like there's ever a time to do the over the top any longer?
Yeah, I mean, honestly, I haven't built up the guts to try an all epiphyseal on a patient that young on the tibia because I'm just so worried about blowing out the proximal tibia. I just don't. I never actually saw it, and I haven't tried it myself. I've watched a lot of techniques on it, but I'm just so worried not having enough space to drill a tunnel through the proximal tibia. And it's such a steep angle to do it. And so with those really young patients, I've still gone to an IT band, and I've done a few of them now, and I so far I've had good results, but again, that's like a very small patient population. And initially I felt like one kid's IT band just kind of loosened up. If it just felt very lax after a few months, and so I got a little worried about that. But now that he's kind of done more strengthening and he's now about a year out, it doesn't feel as lax anymore. So I don't know if that has something to do with just improved muscle mass or strength around the knee. My other IT band, it feels pretty solid. So I've been happy with them so far. So in those young patients, I'm probably just gonna go ahead and do IT band. Um, there's good results, and something I didn't know. I was talking to somebody from the UK. Apparently, IT band is also used in adults there. I don't know if you knew that or heard about that, but they'd go through a like an all epiphyseal-ish or femoral tunnel and bring the IT band through a femoral tunnel and then just attach it onto and they may bring it through the tunnel on the tibia as well, and so in adults. But yeah, they're using it for some of their adult patients as well.
Wild. That's wild. Interesting. My other question was going to be exactly what you just pointed out, which was that um, on the all epiphyseal on the tibia, if I've got an older Tanner stage, I think I'll do an all epiphyseal on the femur and just drill through the tibial physis.
Mhm.
But when doing the all epiphyseal, I think that probably the most difficult part is that tibia. And we can place the guide in the right spot, and it tends to come out a bit more anterior because the steep angle. And so the question I was going to ask is any pearls on avoiding anterior placement of the tibia because of the steep angle? Do you just place it more posterior, knowing that it's going to still come out a bit
More
anterior?
anterior.
Yeah.
Yeah. Yeah. I mean, even if that guide pin, when placing more anterior, if you're worried about getting to the tubercle apophysis, or the most anterior aspect of the proximal tibial physis, that pin is so small. You're really violating just a small portion of it. So it's likely not going to cause much harm, especially if you know it's going to that the reamer itself is probably going to come out more anteriorly, and so I imagine that it's I imagine it's pretty safe.
Just unfortunately had to do we had to do just a cyclops excision on, I think it was the 9-year-old, but I don't believe it had anything to do with anterior placement on the tibia. I think it was just It just unfortunate development, but he otherwise
Yeah.
was doing great. ACL looked great. He was about a year out from his ACL at that point.
Nice.
Majid
Nice.
or Jeff, any questions?
Nothing from me. That was awesome. Very, very informational and beneficial for me.
Great.
Anybody else? Excellent. I may start doing some bears on some younger patients. If they've got more, I'm still not, I don't know how you are with the bear with mid-substance ruptures. The only failures I've had with the bear, I've had 2 of them fail where they were mid-substance. And so I've gone back to just using it for proximal ruptures, maybe an 80-20, or even, if it's a pure avulsion from the femoral side. I'm not sure that I am, fully believe in the concept for a mid-substance rupture, but what's your experience
Yeah.
with those?
Yeah, I'm totally with you on that. So I feel like I'm probably more so talking patients out of the bear than into the bear. And I'm just like, I'm not trying to, but it's because I don't necessarily, I'm not, haven't jumped on the bandwagon yet. I'm not like a believer just yet. And the thing is, I want it to work. I mean, what a great, how wonderful would that be to have this option that actually we can, guarantee that it's going to work, it's going to heal, and it's a good option, because now we don't have to harvest and take tissue out, especially with these, well, in general. But I'm the same way. This mid substance to like little tiny tibial stumps, I am not a fan of using it on those. I hate not being able to recreate stability right away. It really bothers me. And so I just have decided what my indications are for the bear, and I'm similar to you. The tear has to be like a Sherman type 1 or off the femoral footprint, or it could be off the tibial footprint if it's more of like not necessarily a tibial avulsion fracture, but almost like the sheared, like the cartilage. And I will bring that down and I'll repair that because the tissue is still intact. It's still nice, thick, robust, healthy ACL tissue, and you can recreate the stability like you would a reconstruction. And the bear pretty much goes in as an augment. You're just basically putting a little bit of bone graft in there to help it heal. And some would argue if that is even necessary, since the fibers are still there in the notch and connected. But as of now, that's usually when I am using the bear. But what I still do is I talk to the patients in clinic about it. I think it's important that they know it exists and that it's an option. I talk to them about the risks and benefits of it, and kind of through shared decision making. I will, if they want me to be prepared for a bear, even if it's just like a little tibial stump or mid substance tear, and they are willing to take the chance of it failing, potentially having to do it again, then I'll go ahead and do it. But this after we've had that discussion.
Thank you.
Mhm.
Anyone else have any questions? Okay. Well, Dr. Bridges, thank you so much for spending the evening with us. Really appreciate it. Hope everything's going well in Dayton, and look forward to next time we see you. Thank you.
Absolutely. Thank you so much for having me tonight. It was really, really great talking to you all. And if there's anything I can do or offer, Dr. Frush or EJ, they have my contact information. I'm happy to, do what I can.
Cool. All right. Well, thank you. Have a good night, everybody.
Good night.
Thank you.